Okay, life can be crazy. You're feeling like you're sinking, just trying to find a meaning. It's time for better thinking, yeah, better thinking. Time to tune in. Let's go.
Welcome back to Better Thinking. My name's Nesh Nikolic, and my guest today is Dr. Tayla Degan. She is a postdoctoral fellow at the National Drug and Alcohol Research Centre at the University of New South Wales. She's also a registered clinical psychologist working in private practice, and her PhD has focused on health literacy of people accessing specialist mental health and substance use disorder treatment services. Dr. Degan is currently involved in stimulant research at NDARC and is working on projects which include the TINA trial. She has expertise in working with people accessing substance use disorder treatments and mental health services. Dr. Degan has experience in working across multiple research trials and projects, including a New South Wales health-funded randomised controlled trial, the Continuing Care Project, which examined the effectiveness of a telephone-based continuing care intervention for people discharged from residential substance use disorder treatment services. She also has experience in the evaluation of health services such as residential rehabilitation. Dr. Degan has also previously conducted lectures in psychology for the University of Wollongong and also for Charles Darwin University. I'm looking forward to sharing today's podcast with you on health literacy and how important this topic is to consider both as a clinician and also as a consumer of health services. Enjoy. Tayla, big thank you for coming on to the show today, and I'm really excited to talk about health literacy in particular around the mental health world, and also a little bit on the substance use space as well, because I know that's something that you've worked in quite significantly, at least in the most recent times. So yeah, thank you, and appreciate you coming onto the show.
No worries, Nash. I'm really stoked to be here. Thanks for having me.
I like starting off with finding out a little bit more about our guests and in particular, how you got into that interest, that space. So maybe you can talk me through a little bit about that as a starting point.
Yeah, that sounds good. So I'm a clinical psychologist as well as what's called a postdoctoral research fellow. I work doing research out at the National Drug and Alcohol Research Centre at the University of New South Wales and work privately as a clinical psychologist as well. So I guess getting into that, completed my clinical master's degree at the University of Wollongong, and then was convinced, I guess, by supervisors to go on and do a PhD. I kind of did about 5 years of PhD research there, looking at health literacy, as you mentioned, and looking at the concept of health literacy in people accessing mental health treatment, and then more specifically, people accessing residential substance use disorder treatment. So kind of did that for 5 years, and then finished my PhD at the end of 2022, got kind of the role as a postdoctoral research fellow. So postdoc is just post PhD research position out at NDARC over at UNSW. So I've been kind of balancing the two roles since then, which I thoroughly enjoy, kind of wearing both hats, and at the same time, hats at the same time sometimes. So yeah, it's been good.
And what in particular drew you toward the health literacy space? Was it that was on offer of the different topics and it kind of caught your eye? Is it something that you've had a personal experience around? Have you seen others who struggle with navigating the world of health in particular, in mental health?
Yeah, I think it's a really good question. I think it can be really daunting, even starting a PhD for people to go what on earth do I do it on? And it's always really great if you have a passion in the area, and it makes it a lot easier to complete it. But in a way, I guess it came about through my honours year. So the honours being the year before I started my PhD, I did an honours thesis, and my supervisor, I kind of chose my supervisor knowing that he was really awesome, and also knowing that he specialised specialized in substance use research. So it kind of started with, I guess, an interest in substance use research. And yeah, whether that's, I guess, having, some relationship to that in terms of like personal family members and things like that, and being kind of really curious about how to people come about in that way, or access treatment for substance use disorders, and what are the ins and outs of like how it works or why it doesn't work sometimes. And so that was, I guess, my interest. So that's where it started. And my supervisor had kind of mentioned this concept of health literacy. And if I'm honest, and it's kind of what most people think initially when they hear it, it's like, I was like, oh, that sounds super boring. And it's not kind of one of those crazy interesting topics for your PhD or thesis anyways. But I was like, kind of did some research and realized how important it was, and how no one had really researched or looked at health literacy in people accessing residential substance use treatment. And so I did my honours thesis dedicated to doing that. And then that developed into the PhD, which then went slightly broader, looking firstly at mental health populations in general, and then kind of narrowed in more again, doing some further additional research in the substance use field with that concept.
And to help me out a little bit, and obviously some of our listeners too, what is meant by health literacy?
Yeah, so health literacy is someone's personal knowledge and competencies that they might gain through like daily activities, like social interactions with other people, even passed down through generations. So, for example, like through your parent or caregiver. So that knowledge and competencies, we use that knowledge and competencies in combination with like organizational, so the way an organization is made up. And the way it's structured and their availability of particular resources, to then enable someone to like navigate, understand, utilize health information to then access the healthcare system appropriately. So it doesn't just come from the individual's skills and abilities themselves. It also kind of interacts, I guess, with or the organization. The health systems also play a role in how their environment is structured and the resources that they provide. So I kind of like to use the example of if someone was to have, say, lower health literacy, and maybe they, had a cold, and if they were had lower health literacy levels and they were experiencing a cold, and maybe it turned into a flu, they potentially might not know where to go to get help. They might not know that they could probably look up on Google, like, I've got these cold and flu symptoms. What are some treatments that I can look at? They might not know that I can actually just go to a pharmacist and go to a pharmacy and ask over the counter for any kind of medications or any other things that might help. And they might not know that they can go to their GP and check in that sense. So I guess it's just a really narrow example, but someone on the higher end, someone with higher health literacy might have that kind of competency or the health knowledge to go, I've got a cold. If it gets worse or the symptoms get worse, then I go to my GP first, or I can just go straight to the pharmacist and get help there. So people with lower health literacy levels often present with poorer health outcomes. Higher rates of presenting to the ED, going to hospitals, lower levels of social support, higher levels of shame. So it actually kind of impacts on someone quite significantly. And I guess that's why the emphasis on how important it can be.
And why would you say, and I suppose what does the research say in terms of why they correlated in that way? Why are those things somewhat connected?
Yeah, I guess I haven't done that research myself specifically in terms of the general population, but I guess it comes down to, I guess you and I probably both know, like, our healthcare system is extremely complex, and I think it makes sense that you need like a level of skill or ability or knowledge or education around the healthcare system in order to access it the most effectively. And so I guess if someone doesn't have that or hasn't had, someone educate them or provide them with or enhance, to help them enhance those skills and knowledge, then, you know, the healthcare system would be extremely daunting. And people just generally don't know where to go. And I guess, for example, the correlation to ending up in, say, emergency, it could be because their health gets so bad that, you know, their only option is to go to the emergency department. Because maybe they haven't been proactive in their healthcare. So it does come down to that, you know, being proactive as well, and the impact of that if you're not proactive.
It seems like, at least through my experience, that you know, one's locus of control is pretty it is a fairly strong moderator of maybe someone's literacy.
Yeah.
Assuming part of the definition of literacy is how someone can access healthcare. You know, navigate it, that
Yep.
if their locus of control is high, then they're not necessarily going to accept that there's, you know, an extended waiting list, or I just have to wait for the doctor to send the referral. You know, there's kind of like a fear of, can I call the practice? Can I follow up when I've been to pathology? Can I, you know, see whether they've sent it? Can I ask about where they specifically sent it? What was the email? Or, you know, people who can't, who've got low or have got an external locus of control, I should say, might not go out and follow up, versus someone who's got a, you know, a high internal locus of control will you know, push it along. It's almost like project manage their health, so that maybe they're seen earlier, I'll question things more. It seems like that's a fairly important aspect in terms of, I think, mental health in general. You know, low locus of a high external locus of control, I think often is associated with lots of mental health difficulties, because people feel helpless. You know, they're at the mercy of the world, whether it's the medical system or any other. And, you know, it kind of feels a bit scary when you're dealing with medical people. You know, they're smarter, you know,
Absolutely,
and it's true. They are smarter. That's why you go to them. They're very, very intelligent in a very specific area of what you're in need of. So they're clever people. Sometimes it can be daunting.
It is really interesting, and I completely agree. And I think that also, I guess, comes to, you know, the research finding that, you know, that people with lower health literacy levels often have like lower levels of social support and higher levels of shame. And, you know, we think about social support, and I guess that the role that plays in, you know, maybe, you know, people who experience mental health conditions. And I guess, you know, I think about, you know, someone who has social support versus someone who doesn't. And, you know, if you say rock up to the GP maybe for the first time, and you had a really bad experience maybe, and, you know, you kind of, if you don't have social support, you might go home and kind of experience that feelings of shame, like they kind of looked at me funny when I expressed that I was maybe expressing some substance use issues. I felt judged, like that stigma, or interpreting that in some way. I look at that then versus, say, coming home to maybe family or friends or caregivers who you can then have maybe that conversation with around, like, hey, I've had this experience, and then being like, that's odd, like, have you tried this GP? Or, you know, that there's other people out there and not all GPs are the same. And similar to psychologists, right? Like, I guess I even try and educate clients coming in, if they've maybe had like a not so great experience. It's like, you kind of have to shop around, like, you know, you're not gonna get along with everyone, but it's that knowledge that there are other psychologists or there are other GPs to go to that may be able to help. So you're right. Like, I think that encompasses that. Yeah, it makes sense why, I guess, it's correlated with like lower levels of social support and higher levels of shame. Because I think it, you know, I guess low health literacy doesn't correlate with just one thing. You know, it's a whole bunch of stuff. But yeah, it'll make sense.
And that makes sense, because if you are well connected, you've got strong bonds socially, they look out for you, so they increase your internal locus of control by saying, hey, that's not okay. You deserve more. You don't have to just put up with that. You know, there are other options. They urge you to you know, look at other options, and more likely say, so how did it go? Did you follow up? Did you end up contacting it? They remind you as well. They keep you
Yeah.
somewhat accountable
Yeah.
through obviously their care for you, their love for you. So
Yeah.
that
Absolutely.
makes a lot of
Yeah.
sense. And I imagine they can also therefore push their literacy across to you because they are advocating for you,
Yeah.
whether it's doing it specifically or advocating that you can do it,
Yeah,
and
it's that generation
encouraging
thing,
you.
right? Yeah, like the kind of knowledge and competencies can kind of fall through that generation. But even, I guess, on the other spectrum is, having a lack of social support, and then it's like, where do you
Mm,
get that health literacy skill from? And I think that's why kind of research or the definition of health literacy has merged into really acknowledging the role that organizational structures and the resources that they provide play in
yeah.
enhancing someone's health literacy. So, like school, for example. I mean, I don't know when you went to school, but when I went to school, I don't think I was taught anything about the healthcare system or
No,
how to navigate it or where to
no.
get help. I had to rely on my friends and family. And if you don't have that, or maybe they struggle or they have lower health literacy levels, then that can significantly impact on you.
Mm. It's so important because I think as humans, we are novices effectively all the time in life, for,
Yeah.
for, for so many areas of our life where we're doing things that are brand new, whether it's parenting, you're
Mm,
only ever parenting a 1-year-old once, or
mm,
obviously if you have two children, then twice,
mm.
but, uh, you know, that child, you're only ever parenting them once when they're 16, once when they're 20, once when they're 36.
Yeah.
You're always learning what that's like, in your role.
Mm,
And obviously from a health perspective, whether it's mental health, physical health, both, you're often blind to what all that means. And
yeah.
interestingly, even just in the mental health world, I know that I don't necessarily share the exact viewpoint of all of my colleagues.
Mm,
There's many topics that if we stepped into, we might have different opinions.
mm,
And
mm.
so, interestingly, someone who comes and sees me as a client, they will get not necessarily my opinion, but they will certainly get the flavor of how I work, which will be very different to the flavor of how you
Yeah.
work, which will be different to the next person. And
Mm,
hence the importance of that word of, we might call it shopping around. I think it's finding a good fit,
yeah.
something that works for you and resonates. And
Mm,
and that
mm.
doesn't necessarily mean forever. It might be for a period before you say, I need a new voice. It's healthy
Yeah.
to get another psychologist point of view. Even though I've found great value in this psychologist,
Mm,
sometimes stirring the pot is useful. Different language, different perspective, different way that
yeah.
I describe it, different way they interpret it and formulate and so on. So I know from the health perspective, when I've tried to help loved ones,
Mm,
more often than not, you feel extremely vulnerable because you don't know the science, you don't know
yeah.
the data, you don't actually know what you're doing, and you feel
Mm,
very vulnerable to their decision making. And how can you
mm.
possibly question them when you don't actually know? It's
Yeah.
so problematic, and the world of Google
Mm,
makes it both helpful because you can
yeah.
do some decent research at the same time. Literacy about how to read journals. I think,
Mm,
I don't know if you've looked at the replication crisis and the issues around how research is done, and
mm,
um, how it's been somewhat created results that
mm.
are not actually valid, or
Mm.
don't have the utility that they were told
Very
they well, we
scary.
were told they would. It's a major problem. So even our doctors will probably have
Yeah,
difficulties in being able to read all of this. It's just complex. Life is complex.
absolutely. Yeah. Like so complex. And I guess that's why coming down to that like research and, as a researcher clinician, yeah, the importance of evidence, but and kind of knowing or being up to date with the evidence, and then kind of bringing that forth into, say, private practice or wherever you may work. But yeah, it is scary when you think about maybe people not doing the right thing in terms of research, and then the influence that has. But I guess even you mentioning before around how you would have that conversation with a client around, sure, maybe, yeah, probably shopping around is not a great term. I probably need to start changing that term, Nesh. But even what you said, kind of finding a good fit, and for you to actually sit there with clients and be able to have that conversation around that. I think that's even just, I guess, comes back to health literacy, and you kind of as the, maybe not the organization, but as we talked about, it's not just the individual, it's also we play a strong role as organizations or services or healthcare systems to then continually like educate and help people along that road. So clients walking away from that conversation, it might have been the first time that they've ever had someone tell them that, and they're like, oh, that's, yeah,
Mm,
okay. And then
mm.
they might go tell their friends, and then it kind of spreads out from there. So yeah, I guess this is all just emphasizing the importance of health literacy, and why why I did 6 years of my life dedicating research to it.
I like the aspect, and maybe you can talk a little bit more about that as well, in terms of health literacy also being entangled or connected with how organizations
Mm,
set themselves up. I can see from the inside of running a practice that the things that we do, how they either help
mm,
or hinder a client's process. I use the word friction
mm,
because I think wherever there's little friction is where people tend to move into. Wherever there's
mm,
high friction, obviously reduces the number of people going into that space. So you can kind of funnel, you can shape how people will engage, for example,
mm.
with the practice and how they'll make bookings or
Yeah,
so on and so forth, by the way that you set up the structures.
yeah.
And obviously the same is true for everything.
Mm,
Classic behaviorism, right? Whatever you go out and punish through friction, through
yeah.
making it difficult,
Mm,
versus whatever's rewarded by making it easy. This is why credit
mm.
cards are so
Yeah.
well adopted,
Yeah.
because the friction is low. You got a little
Mm,
card, and you tap it. Well, guess what? Now you don't even need a card. You've got
mm,
a phone, you hit a button twice, and you tap that. It's with you constantly. So,
mm,
there's a frictionless experience.
mm,
Can you talk us through a little bit about how organizations are set up, and obviously the
mm.
research, what you've read and all that?
Yeah. Yeah, well, I guess in terms of obviously, organizations, they're going to, the way they're set up is going to be different depending on, I guess, the industry or what we're talking about in that sense. I guess maybe a couple of things, and one of those might be the research side, but then maybe initially it might be worth just off the back of what you were saying around, say, in private practice world, the kind of, again, role we play in someone's experience. Like even recently in private practice, due to you're probably well versed in this, but due to the Medicare of the year ticking over, it sends people crazy thinking about sessions and number of sessions and Medicare and what do you get rebated and all that type of stuff. And, calling particular services or say like a reception team calling particular services to try and figure out like, what is what do we do about this? We were kind of recently talking, I was kind of providing my reception team with some education around like what we actually do in that instance. And it's crazy because they were kind of saying that the information they were getting from two different sources were completely different to what I was saying. And we were just kind of talking about how as a team or we have a level of responsibility to get that right. So then when clients call, it's like we can then, it kind of starts that ripple effect, right? Like if a client calls and we're like, I don't really know, not really sure, then they're probably getting off the phone also unsure and not knowing. Whereas if we can actually, be that first port of call for, say, clients calling and we can educate people on like, yeah, this is how you get a mental health care plan, or, just because it's a new year doesn't mean you have to go back to your GP necessarily, and all those types of things. I guess that just emphasizes the ripple effect in terms of that, the, I guess, higher organizational structure. You can kind of look at it in terms of, say, reception, and then like us as psychologists, and then the responsibility that we also have, as we were saying, in terms of educating people in that kind of session. But also it comes down to, say, like the homework that we give people. I know, yeah, you might like practice ACT, and I do some ACT and some CBT and a whole bunch of stuff, and it's like, homework or practice tasks, as I like to call them, is something that I like to implement for my clients. And there's a difference between me giving a client a worksheet and just being like, yeah, do this in the next week, versus actually sitting with them and checking their understanding of what I'm asking, ensuring that they are aware, or that they even want to do that, that they're aware of what they're doing, and the outcome, or I guess maybe the friction, like, well, the outcome would be likely more positive if I was to sit there, educate, versus just throwing it in their face and kind of going on their way. And I think there's research that suggests, there's a lot of research on homework in clinical practice. But I guess if we were to think about it from a health literacy perspective, I guess they're just small examples of the impact that, I guess, an organization, it could be from the front desk versus to the actual practitioner, the role that we have throughout, like, just constant interaction with clients in terms of helping enhance people's autonomy, or helping enhance people's health literacy. So I guess that's kind of that side, in talking maybe about those types of things in terms of maybe you and I's experience as psychologists in private practice. And then I guess yeah.
It's really an important point, I think, that you make in terms of the Medicare space, because we've certainly had the exact same difficulty about trying to, educate our clients about how these 10 sessions occur, and what does a calendar year mean versus what does a annual or 12-month period mean, and how it goes across. What's really interesting is that we also find it very difficult to appreciate and understand it from Medicare themselves. The number of times I've called Medicare, been told one thing, felt that it's not quite right, phoned the same number, and then had a different operator say something different. And unfortunately, none of this is done in writing. This is all conversational. So none of this really stands, and so we don't have confidence, or I certainly don't have a confidence half the time of what I'm being told. Usually as human beings, we're fishing for a particular response because that'll be the least friction, it'll make my life easiest. So there's even a bias in there about how we ask a question. There's this kind of awful experience of when people don't know, they don't say I don't know. They make things up. And so I think, and not everyone obviously, but it's certainly a pattern that we've both experienced, is to save face, people make something up, and it's crucial to have accuracy. There's almost like a shame of saying, look, I haven't come across that, or I can't remember. Let me get back to you. That whole experience can change in terms of their trajectory, depending on someone who's making something up, which doesn't stand true, doesn't hold up, versus some honesty, but still being able to say, I'll learn something in the process because I'll find out and then I'll get back to you. But that's a friction point, right? People are busy, so they don't want to look into things, at least on average, has been my experience.
Yeah, I mean, that's really interesting because when I've measured health literacy in my research, so it's changed a lot from like back in the 1970s when the concept was first introduced. It was measured using like reading and writing ability. So basically, like your health literacy was determined by how well you could read and write.
Your actual literacy,
Yeah, your actual literacy, it implied your health literacy, which we now know is incorrect. Sorry, not incorrect. There's way more, and that's like
Sure.
one kind of aspect of it. So it's a really important aspect. We call it
Yes.
functional health literacy. So with someone's ability to read, write, things like that. But there's now, well, not. I mean, it's been quite a while now, but this big shift towards looking at health literacy as a multi-dimensional construct. And I guess that's just linking to what you were saying before. One of the measures that I use is called the Health Literacy Questionnaire. And that's a really kind of well-validated, well-used way to measure someone's multi-dimensional health literacy. So the World Health Organization, the Australian government uses it now in like the household surveys to measure general population health literacy and things like that. So it's a really good tool. But that tool has 9 domains of health literacy. And one of those is ability to appraise health information. So kind of what you're saying, it's like it's also your ability, like, if we're talking higher levels of health literacy, when I'm given information, it's like I'm able to appraise that information or to really like figure out whether that's accurate and to maybe get a second opinion. So we're talking about maybe going to a doctor for maybe they're concerned about a lump or whatever it might be. And it's like, you know what, I'm going to go get a second opinion. So it's also the ability, that is just one kind of the 9 aspects of this multidimensional health literacy construct, where you're right, like, calling Medicare, and I've absolutely had the same experience, hearing one thing and then, maybe hearing something else. And it's, I guess, where then if we have high health literacy, have maybe the knowledge that, hold on, I can compare these 2 pieces of information. I can maybe compare it to what I've read online. I can also compare it to maybe my peers in private practice or their experience as well, and come to kind of a more educated, maybe accurate conclusion in that sense. So yeah, you're absolutely right. Health literacy kind of encompasses all these domains, and that's one of them, that ability to appraise information.
It's interesting because when I think about that whole concept of trying to find information, someone just speaking off the cuff is a very different experience than like if I call the APS professional advisory service. I don't think I've ever experienced a scenario where they haven't pointed me to the guidelines, where we've had a conversation, but they've then sent me exactly the section I need to read as well. And I know psychologists do this, and I can put my hand up as well, where we assume something rather than going back to our guidelines, and code of ethics and reviewing them, because assumptions are so easy, but we really need to go out and read what it says for ourselves, because most of us have not read it from start to finish. Which is kind of funny. Like we all abide by them in theory. Truth is we don't, because we haven't read them from start to finish. It's kind of like assumed that we're going to do the right things. We've gone through uni, so these things have been reinforced. If you work in a group of people, there's more likely that someone will, point in the right direction or question it. But even then, often people are just saying, oh, that's not right because of blah, 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 but they haven't reviewed the actual code of ethics and see what does it actually say. And I know I've practiced for years at times assuming something, only to then open it up another time and go, oh my God, I've
like, oh God,
been doing this technically incorrect. What's fascinating, here's a fascinating one, and this is like even about practice literacy, which I think in so many ways still applies. Informed consent is not going out and getting a client to sign a form. Informed consent, we all do that because it's very wise to do that, all psychologists, because it has a very strong legal standing should something occur, to say that you've gone through this. But the truth is, informed consent cannot occur unless the conversation has been had. So it has to actually be in session. And it's a bit funny because if you look at all the informed consent guidelines, honestly, if you did everything that they asked you to do, I reckon it would be 3 sessions.
Yeah,
it is astronomical what they expect that we go and do. But the world works in a different way, so you can kind of just say, here are the 3 times I can break confidentiality. We're engaging in psychological services. Any questions? Obviously you've got informed consent. You can withdraw it at any given time, and but that doesn't actually. It's not how we practice. So it's really funny to have one thing said and then another thing done. But that's kind of how, the literacy is, that's how it is. But as a practicing psychologist, the whole of Australia does it that way. We get a signature, we discuss it in session. We provide that we provide that you can withdraw it at any given time. Obviously, all opportunity to ask any question at any given time about what therapy we're doing, what the service is, etc., etc. But if you look at the guidelines, they're much more complicated than that. There's so much about what we're supposed to explain and risks and this and that. Like, no one does that.
No.
Yeah. So it's interesting anyway.
Yeah, it is really interesting. And I guess, even around that informed consent, like you were saying, the conversation, we have to have that conversation and ask any questions. And it's kind of also comes down to maybe what we assume people know. And we just assume if we have the conversation and say any questions that they'll be like, no, all good, I get it. And again, comes down to, this health literacy stuff. And it's like, but do we know that they've actually understood what I'm saying? And I'm not saying at all that in every single session with every single client, I ask them to provide, to tell me, teach back. We call it the teach back tool, which is a health literacy tool. But to ask them to teach it back to me. But I definitely do in some instances when I'm maybe slightly unsure whether they have really understood it, or I'm maybe I just feel like going the extra mile that session. But it just comes down to, again, us maybe assuming, same with homework, giving a homework task, we just assume that they know. I've even started in my practice to check in about reading and writing abilities. Like, hey, how do you go with if I was to give you a whole bunch of information? Some people love it. They're like, give me handouts. I want written education information about anxiety or depression, and I'll go away and read it. Whereas if I just give that to someone without actually checking in with how they cope or how they like information to be presented, then that could be, really difficult for them. And they're probably likely going away and just, maybe chucking it in the bin or not ever reading it, or maybe reading it and not really understanding it. So again, I think it's this, and we're humans too, and sometimes we're dealing with time constraints and things like that. But we often kind of assume people's health literacy, and I think that is the problem. And because then how can we expect people, for example, people accessing substance use treatment? We know that their relapse rates are really high post treatment, and it's the way. That is because of a whole bunch of things, not just health literacy. But, we, I guess, maybe are sending people on their way, assuming that, you've done residential treatment and you know what to do. And so I think it's the assumed knowledge that is really the problem. And I guess one of the conclusions, around the PhD or recommendations, which is probably jumping ahead a little bit, but is to measure health literacy. And again, I don't do this in private work. I don't provide people with a health literacy questionnaire and measure that, which potentially I should. But again, it's emphasizing, say, for example, in residential substance use treatment, that we should be measuring people's health literacy skill when they enter treatment. So then we have a really good idea of what they maybe struggle with, what they're really good at, and then can use like an individualized, like tailored treatment plan to kind of help them in that way. So, sorry, I know I kind of jumped around a little
No,
bit there,
no,
but
just can I ask what I mean, I think we almost kind of said the same thing in terms of how we practice is sometimes guided by, time constraints. It can be very difficult to spend,
yeah,
most of a session, if not multiple, on consent. If I were to do it properly, and I
yeah,
don't believe the tolerance level would be there, or I genuinely don't even think that Medicare would desire that.
yeah,
I don't think that was the intent
no,
of
yeah,
consent. Um, Similarly, your PhD recommendation, one of them at least was to measure health literacy.
mm,
Yet there's some sort of friction in why that's not being done.
mm,
Could you reflect on that, or talk that through? I'm fascinated because I like to observe myself and try
mm,
and it's almost like a way of doing, whether it's core beliefs or fusion,
yeah,
um, with oneself to be the observer.
mm,
What is it about that? Because when you were talking about asking a client, what's
mm,
the format in which you would like information delivered outside of session? Do you want
mm,
me to provide you with a video link?
yeah,
Would you like written handouts?
mm,
Are you more of an audible person? What are the helpful um, submodalities that I can provide information in? That I think is so useful because it actually
mm,
means that someone's much more likely to engage with the material.
mm,
And so I can see that the extra 5 minutes of preparing that probably
mm,
has immense value, because otherwise they probably just won't even, or less likely to engage with the material, and it's going to create more cognitive load for them to engage with it.
mm.
So yeah, I'm curious to know about the health measuring health literacy, how it happens
Yeah,
sometimes and not other times, and what do you think kind of
yeah.
creates that for you as well?
I think it is such an interesting and probably a really important question or thing for me to even reflect on, and something that I do reflect on quite often. Again, being researcher clinician and dedicating, majority of my week is doing research. And the whole point or passion of research is to develop an evidence base. And then I like that as a clinical psychologist, I can, maybe be up to date with the research and kind of implement that in some way in private work. And here I am kind of emphasizing health literacy, kind of saying that I've dedicated 6 years doing an honors and PhD looking at it, and I still don't measure it. So I find, yeah, I actually, a part of me is like, oh, I feel like my next client, I'm going to get them to do the health literacy questionnaire and going to see, maybe even test that, like see, does that make a difference in terms of how I work? And it probably will. Um, and I guess in terms of maybe beliefs or reasons why I don't do that or have not done that yet, I think maybe partly, maybe because my hyper awareness of health literacy, um, as a construct in terms of its importance, I feel like maybe I naturally err on the side of practicing in a way that maybe implements techniques naturally. Maybe again,
Mhm.
not just assuming, maybe I haven't measured their health literacy, but I'm also maybe not assuming. Sometimes I do. I'm not, saying I'm amazing all the time in terms of health literacy, but maybe trying not to assume in that sense. So if I don't measure it, then I can't assume because I don't know. And so maybe if I then work in a way that my practice continually has maybe health literacy in mind, like for example, when providing homework or explaining concepts or writing out worksheets with clients, um, then I'm like, maybe is that enough? Like, I guess is my thoughts around why I do that. And I think the reason is, and what you were saying before, is maybe because of time constraints.
Mm.
And particularly if clients aren't coming privately and we're under a Medicare model and mental health care plan, 10 sessions, I mean, I personally think 10 sessions enough for anything is usually, is not enough, to kind of cure someone's anxiety or depression. We need much more time than that. So
Mm.
I think there is an element of it. It could take a session doing that type of stuff. Like, I guess
Mm.
implementing it, I would say, would maybe take about maybe 10 minutes. So I guess, again, you could probably get someone to do it prior to coming to see me, which, now that I'm saying that, I actually think that would be a really good idea. I don't send any of my clients like stuff to do before they come and see me, but this is something I'm now thinking of. And then, scoring it, like, that's having, the ability to score it and know how to score it, and then being able to kind of feed that back to the client. I think it's a time thing, if I'm
Mm.
honest.
It's
Yeah, and
interesting because
yeah.
I think about this stuff so much, like,
Mm,
when do we send forms and
mm,
like, because I am fairly sort of tech, I wouldn't say savvy, but interested.
yeah, yeah.
And I've always kind of weighed up and questioned, when do you send these forms? Because I always think about it from that friction point of view.
Mm,
Uh, Part of someone's experience of engaging in health service is also about how laborious it is for them. And
mm,
as much as it would be helpful for me to get everything under the sun available, for me and the clinicians working here, is that can also be part of the issue of access. So
mm,
there's a conflict in that. So if we
mm.
require clients to do A, B, C, D, E, F, and G,
Yeah.
um, to then access our service, that reduces that efficacy
Mm,
of being able to get into the service.
mm,
Um, and so there's great value, but at the same time, there is a effort required, and how we balance those, I think, is quite complicated.
mm,
And as you say, when there is a limit, question, starts to become, well, what is more efficacious in spending more time
mm,
in informed consent, or
mm.
doing the health literacy questionnaire, or any other questionnaire. Is
Yeah.
it sufficient enough to do something that's a screener, that's a bit more brief? Can we integrate
Mm,
it into our language, into the way that we ask, clients to feedback what the homework or sort of between session experiments are,
mm,
and the like. It's interesting to consider this, because there's no doubt that health literacy is important, and in particular, I think if someone dealing with substance abuse difficulties is
mm,
trying to seek help, there's a lot of things that tends to go with that, and often,
mm,
obviously, lower social support is quite common. Likely to be surrounded by others that have got those similar difficulties. So your buoyancy of social networks
yeah.
to support ongoingly, in a regular manner,
Mm,
is reduced and like. So
mm.
it's quite interesting. It, are there certain mental health difficulties that have a stronger correlation with health literacy levels? Is there lower health literacy levels in certain conditions, so to speak, or life experiences?
Yeah, it's a really good question. I haven't actually looked at that in terms of my research, and I don't think anyone has looked at that, given I was, maybe the first researcher to look at and when I say look at health literacy and mental health and substance use, it's using the multidimensional construct, not just that kind of unidimensional, like we're talking earlier, functional health literacy, reading and writing.
Yeah.
So, yeah, in my research work, no, we just looked at a kind of mental health population. So, people accessing treatment for their mental health. So it was like like a mental health service. So I guess that may then potentially mean that we were getting like more people experiencing more severe mental health conditions. We weren't just measuring kind of general population and their mental health experiences. But I guess on average, so what we did do is part of my PhD research, we so we kind of obviously measured their health literacy, found that the way we measure it is using like this particular analysis. Sorry, the way we analyze the questionnaire, the way I have done, is by using this particular analysis that pulls out profiles of people. So it basically groups the population we're sampling from into different profiles. So we can then like look at where their strengths and weaknesses are on the different dimensions. So like there's like, we named them like low, medium and high. We always got 3 profiles. That wasn't predetermined. That's based on statistics. There was always 3. So yeah, we named them low, medium and high because that's based on their results on the questionnaire. They were the lower group, there was the middle group, and then there was the people who had higher health literacy. So I guess the real emphasis is that like it's not a one size fits all. And I guess this comes down to that problem is, we're not talking about developing a health literacy intervention and just giving that to every single person because they're all the same. People presenting to these services and same with substance use treatment are fit into different profiles, and they come with different needs and they present with different strengths and weaknesses or difficulties. So I guess in terms of the mental health space, we didn't see if that was correlated with any particular mental health conditions. I can't even remember why we wouldn't have done that now that I'm thinking about it. I don't know if it was because of maybe small numbers, and that's what I'm thinking. But we did compare the health literacy of the mental health population, so again, people accessing, mental health treatment, to like the general Australian population, so the ABS data that we had, and also a population experiencing like a physical health condition. So I don't know if I had mentioned this, or maybe it was in our pre-chat, Nesh, that so much research goes on in health literacy in people experiencing physical health conditions, but barely anything in the mental health space. So that's kind of why we compared it with physical health. When we looked at that, the people in the mental health condition, regardless of what profile they were in, so the low, moderate, high health literacy profile, were lower on average. So the lower and moderate groups, compared to, say, the general population scores, and then the people experiencing a physical health condition experience lower health literacy. So overall, I guess we can say that they, and potentially due to a whole range of things, and some of those you previously mentioned, they do experience lower levels. So I guess that's I guess the main core point is that.
Taylor, can I try and clarify?
Yeah, go ahead.
Is what you're saying is that people who are accessing mental health services on average are found to be within the moderate or the low, or sorry, medium or low health literacy scores?
So it can be a bit confusing. So when we're looking at just the population, so just sampling, say, looking at the health literacy of people accessing mental health services,
yes,
and similarly with people accessing substance use treatment, there are, in that sample, people have low, moderate and high health literacy, right? So they don't all have moderate or low. There were groups of people on the smaller end, so smaller percentage of the sample, did have high health literacy. But irrespective of that, when we then just looked at their health literacy and compared it to the general population, people in the moderate low profile were still lower on average compared to the general population. So I guess in maybe more simple terms and non-technical language, that they have worse health literacy than the general population. So people with mental health conditions.
Wow.
Yeah. So same, again, similarly with substance use. So I guess it's around like, here's a population that really struggle, or struggle maybe more so, or there is a subset of that population that struggle a lot more than the general population do.
I wonder whether there's a moderating factor there, or not moderating, a correlating factor, which obviously there is, because that's what you guys found. But maybe, for example, someone who seeks medical support for, let's say, arthritis.
Mm-hmm.
Arthritis is not something that is moderated by how you think.
Mm-hmm. Yeah.
It's not moderated
Mm.
usually by life circumstances.
Mm.
Yeah, maybe I'm wrong here. Maybe there are some, how you eat and so on and so. But generally speaking, those things are not things that we can actively kind of be more resilient to or buffer from as much, potentially.
Mm.
And maybe people who are having difficulties from a mental health space, or whether it's, the substance abuse,
Mm.
maybe that is a moderating factor that therefore correlates with why they're feeling the way that they're feeling, and obviously then accessing support. Because obviously if I get a rash on my body, that probably doesn't say anything about my psychological resilience. And that whole idea of, a higher internal locus of control being connected to higher health literacy. If I have high internal locus of control, I can still get a rash. It doesn't matter, right?
Yeah.
But if I've got a high locus of control, internal locus of control, I'm maybe a little bit more buoyant, a little bit more psychologically resilient. In general, as on an average basis. Maybe there's something there. I'm just kind of postulating.
Yeah, I love that though.
But yeah, that's at least the connection that kind of pops up in my mind of why there might be an average difference there between the general population and the population that accesses mental health services.
Yeah, I think I can absolutely see, why that, why you've thought that as well, and that makes it makes, I guess, logical sense. I think the difficulty with, like pinpointing exactly why is, I think
It's
it's because there's,
multidimensional.
yeah, and it's so difficult, and it's, similar when when we talk about people accessing substance use treatment, and we look at relapse rates, and I was really interested to see, did health literacy, we didn't measure relapse rates particularly, but we followed up people who left residential treatment. We followed them up at 3 months and 6 months post-treatment. And people in the, I guess I was interested
And
to
was there
kind
a
of think.
baseline as well?
Yeah, yep, sorry. Yeah, we had baseline, 3 month and then 6 month. And I guess I was curious about this point around, like, does health literacy play a role in relapse, or how someone goes when they leave treatment? We, as I said, didn't measure relapse, but we looked at health outcomes and treatment outcomes. And again, when we looked at the baseline data, so when we're comparing over time, we look at, as you said, the baseline data first. So the sample of people accessing residential substance use treatment services, again, could spread into these 3 profiles again. So lower, moderate, and higher. So again, I'm not saying that everyone who accesses treatment was lower health literacy, but in comparison, when we're looking at that population, there were groups of people who did present with higher levels of health literacy. What we did find, though, is that over time, so when people left treatment, what was really cool is that everyone improved to some degree. So scores from baseline to post-treatment, everyone had health literacy improvements. And, residential substance use treatment, they don't implement a health literacy specific intervention in that treatment. So it just goes to show that maybe naturally accessing that service, they're doing a good job at helping people with their health literacy and improving that over time. So that was really good. But what we did find is that people in the lower and the moderate category never improved to the level of being high. So they were still worse. Like they were still struggling more or had lower levels compared to the high group. So that everyone improved, but these two lower groups, lower moderate, just didn't improve as much or to the same level as the high health literacy group. And what we found is that the people in the lower health literacy group, it was related, they had poorer health outcomes at the follow-up. So poorer quality of life and higher psychological distress. And I guess that's the key concern, is that again, we're not saying that health literacy is why they're experiencing higher psychological distress or lower quality of life, but this group struggle more, and this group, have lower health literacy, but that they're also presenting with, or they're getting poorer treatment outcomes, or are more just psychologically distressed or lower quality of life. So, again, it's not causation or correlation in that sense. And I guess coming around back to talking about relapse, and it's never going to be just health literacy. And I wish I would be, it would be very great if that was the key to successful substance use recovery. But it's so much more. And as you kind of mentioned before, this is a population who are dealing with so much, and so many challenges. But yeah, I guess just for future treatment, it's kind of around highlighting that maybe we do need to measure people's health literacy levels when they're at the point of accessing intensive residential treatment for, say, a substance use disorder. And we're flagging this group as after treatment still struggling more on those outcomes. And so when we do look at people's health literacy, can we identify the subgroup of people who are on the lower end, and then can we do more in treatment to really help bolster that for them, particularly when they exit? So
that's really fascinating, because although everyone's health literacy increased, whether it's high, medium, or low, the control being that they all access the same service, so they all experience the same information and education and the program. But those in medium didn't jump up to the high category necessarily. They did improve, but they didn't kind of level out. There's another, that's why it's multidimensional. But there's a whole lot of factors why health literacy still didn't jump up to that higher level. And I'm assuming, and please correct me, that of the participants, there was a smaller number of participants that were in the high literacy category than there were, at least on I suppose, number of participants than those that were in the medium or the low. That there's obviously some factor or factors that are contributing to that. And we want to get people into the high because it seems like it does buffer to a level, but even the program doesn't necessarily bring it up to a level. There's something, that's occurring. They walk in different and they walk out different, even though they've all improved. Fascinating.
It is fascinating, and I guess I guess one thing to emphasize, and maybe it's more for listeners, is around the, also remembering that when they access residential treatment, I guess the issue with research is, and maybe in terms of research that involves maybe psychological treatment or residential treatment or something like that, is it might not always be identical. So we can't, I guess, guarantee
My apologies.
that, no, you're fine. I guess just in terms of just emphasizing that, we didn't measure the exact treatment they received. So we didn't actually look at, which would have been really interesting. We didn't actually look at, some people might access like a psychologist or a counselor and other people might not. And other people do day programs or outreach stuff or employment. So I guess just emphasizing there's so much variability, and that's why it is really difficult
good
in measuring. treatment.
It shows I've been practicing for too long outside the research realm. Good pick up there. But you're right. There can be, in actual fact, vast differences. It's not a
Yeah.
controlled environment. It's not
Yeah.
like this is a perfectly controlled by any stretch of
I
imagination.
wish.
People can, participants can choose to participate in a particular session or program or
Yeah.
to skip it. They might go do an external AA program while they're still in it or not.
Yeah.
There's so many variables. You could see a psych or not, while you're there for some
Yeah.
individual work as well.
Mm.
The sky's the limit. We
Yeah.
don't, these are not jails. These are voluntary places that people say, I want to be involved in this, and hence, it's more of a tailored, but there's a group aspect. So
Yeah,
yes,
absolutely.
good point. Having said that, it's still an amazing environment. They can
Mm.
say it actually
Mm.
controls for a lot. A lot more than
Absolutely.
if everyone was just doing their own thing.
Yeah, completely.
The variability
Yeah.
is much greater and much more difficult to control for, at least
Yeah.
to look at validity of those things. But
Yeah.
yeah, so fascinating, so
Mm.
fascinating.
And I guess all of that probably just emphasizes, you know, I guess I'm not coming here and talking about health literacy to say it's the be all and end all, right?
No,
Like my research definitely didn't, factor in all different confounding variables and all the different things that can happen or be different between people. But I guess what it is important and what it did highlight is that like some people are going to be different in their health literacy, and some people are going to experience lower levels and some people are higher. And yeah, what we know is that those with lower levels do experience poorer outcomes, and even in the general population, significantly more health disparities, and even higher rates of mortality and things like that. Like, it's really, really concerning. And then you throw that into looking at a population who are super vulnerable at times, and people accessing or people experiencing a substance use disorder, and as we've briefly talked about, that they are dealing with usually a whole range of other things. It's not just their substance use. And so, health literacy, I guess, it's important to kind of consider that within that environment, to think, maybe if we do just something more, it can kind of help in some way. And I guess the research has suggested that, yeah, I think it would help them in some aspects. Definitely, maybe not, change their life or, significantly improve their substance use issues. But I still think it's valuable, and I still think it's really important from organizational perspectives that are working with people experiencing mental health conditions, and then more specifically substance use issues. And then, as we've spoken a lot about today, Nesh, I guess like us, from being clinicians just on the ground in a one-on-one setting, the importance and value of just considering it, potentially maybe not necessarily measuring it in our setting due to various constraints,
sure.
but yeah, like really considering what that is like for our clients.
Yeah, absolutely. Something interesting that just popped up in my mind
Mm-hmm.
as well. And I'd love to hear your thoughts on it as well. Uh, when we are measuring, uh, looking at how people can navigate, understand, sort of utilize info,
Mm-hmm.
access healthcare, I imagine some of those aspects are quite similar in nature, whether it's on the physical side, i.e., how to access um, these services. I'm guessing here, by the way.
Sure.
But I think there's a real genuine complexity in the possible difference between how you understand and utilize info when you're going for a physical ailment
Mm,
versus going for a psychological ailment, so to
mm,
speak,
mm,
where it's probably a lot easier. And look, it's not easy and straightforward. I know I had a family member recently have a very significant surgery,
mm,
and you're bombarded with information.
mm,
They give you this beautiful booklet, um, and I took charge of
mm,
all of it. There's just so much in there, right? And it's all
mm,
evidence-based, and it's
mm,
absolutely fantastic. And it explains, this is what's going to happen in, the first few days, this what the next several weeks, months, up to a year. And it is so thorough. It is absolutely amazing. And clearly this is a booklet that's handed out probably to every patient that goes through for this condition in Australia. Um, so that was kind of a bit hard to navigate because there was just so much. And there were some things that felt a little bit ambiguous because you just don't know the field. But I think with psychology, it gets even more ambiguous
Yeah.
because it's just something really hard because it's so contextual to each client. We don't necessarily give, these really specific handouts that just say this is what exposure therapy is. At least I haven't done it in my
Yeah,
practice.
no.
I've never heard of anyone doing so. We're actually going to give you we would try and assist very much on this is how we would do exposure therapy for you. But that can get a little bit complicated and good hierarchical sort of exposure. It does it very well. But there are so many complexities, and I think part of the challenge and probably what your research has looked at and what the measurement does, it kind of says when a client leaves the room, how confident are they in utilizing what they've just heard, because the moment we leave, another question pops up and we don't have that answered. And then we've got another question. So we lose confidence in, should I be doing this? Should I not be doing this? How does this work? And that must be really difficult from a mental health perspective because it's not always so black and white. And even as a clinician, it kind of feels a bit odd to say, here are like 3 really black and white, and that's all, without the nuance, especially being an act therapist. Everything is about understanding it, not the strategy. I can tell you how to do diffusion, but the nuance of not trying to get rid of your thought is much more important. To be the observer is more important than just practice the thank you mind strategy. So maybe there's something there about why mental health is harder to have health literacy in potentially. Once again, just postulating. Theorizing, but there's clearly a need because it does show that there's better outcomes with a high in general, at least with a higher literacy rate.
Yeah, and you're right. And I guess as we said at the end of the day, like we can't, I guess, control or know everything that's going to impact on it. But yeah, clients bring stuff to the room that I guess changes or what we might do, and we also bring stuff to the room that might change things too. Like no psychologist does. It's kind of that controlled treatment, right? Like I don't think any psychologist probably does identical treatment. It can be really subjective in terms of how someone might work at times. But yeah, I guess the emphasis is you're right on this. Like it is important, and maybe it's just worth us as maybe clinicians and as researchers or as people to just develop our own awareness of like what health literacy is, and then how to kind of maybe try and observe that in a client, and maybe it's not administering the health literacy questionnaire, but maybe it's like what are some tools and strategies that I can be aware of, or what are some techniques that I can be aware of that I can maybe start to implement in my practice in a way that is going to bolster someone's health literacy, or maybe gather a better understanding of their health literacy without specifically measuring it. Because I think, as the definition of health literacy says, it's not just the individual's skills. I think organizations have a level of, or the services have a responsibility as well. Even just as an example, I was saying so many people present with lower levels of health literacy present to the emergency department or have higher rates. We know that people experiencing substance use disorders will also access acute healthcare at higher rates than the general population. versus proactive services. So they access proactive healthcare services like maybe GP or psychologist less, and they have really high rates of presenting to the emergency. And I guess my thoughts is when someone with a substance use disorder, maybe having difficulties, presents to the emergency department, maybe what's the emergency department doing about guiding them towards like, hey, next time you actually can just go to your GP, or have you heard of this health service, or thinking, I guess, about them presenting to the ED because maybe they've left something too long, or they've been struggling for too long without seeking proactive healthcare. So, and again, people in ED and nurses and things like that, I don't work in that environment. I can only imagine the last thing they're going to do is, I have time to hand out a health literacy questionnaire. But again, it's, maybe it's about just being aware of people's health literacy and really kind of helping people understand like where they can go, what they can do. And, if we're working with a client and we're like, we kind of gather they have really good health literacy based on our interactions and things like that, then it's cool. You can just maybe go about doing your normal stuff. Maybe they're the one that you kind of send papers to because they really like reading stuff and things like that. But I guess it's different for everyone. So tailoring it and being really individualized, I think is really, really important.
It's very, very prudent to be considerate of this, I think, in all aspects, whether it's on an individual therapy basis, whether it's on a systems base in terms of how an organization runs, what are our regular protocols, and also how we want to shape potential literacy to guide future interactions, as you say, like for example in hospitals. And the lovely thing about this is we can postulate, we can go and hypothesize, we can make assumptions, and that's all part of trying to figure it out.
Yeah.
In essence, it's saying if I'm doing those things, I'm mindful of it, which therefore means I can at least try and check in a little bit more about how well my clients or the system or the organization can engage, obviously utilize the information, have better engagement and navigate through the different parts of it, because it's not usually just like you just come in, you purchase an item and you leave. All of those things are really important. Before I let you go, what are you currently working on in your research? And maybe you can also share with our listeners a little bit about your own private practice if people want to reach out as well.
Yeah, so I have taken a slight shift this year or last year, I should say, in terms of my research. To health literacy is still definitely there, slightly on the back burner, but I guess this year for health literacy stuff, maybe starting to think about some intervention work or testing out or developing interventions, maybe in residential treatments or for people experiencing mental health or substance use disorders. So that is there, very much so something I'm really passionate about. I guess currently working on like other trials at NDARC where I work. Currently working on the TINA trial, so doing it's like a big kind of randomised control trial looking at mirtazapine, which is an antidepressant, and actually seeing if that helps people who are dependent on or have a methamphetamine dependence, and actually see if mirtazapine impacts on their methamphetamine use over time. So probably be a whole nother podcast on what maybe that involves and the intricacies of that. But it's called the TINA trial. If anyone's kind of interested in, I guess, that brief blurb, they can look it up. And again, I can provide the website. But that's definitely super unique for me to kind of be involved on a drug trial. I'm not a psychiatrist, so I'm learning a little bit about pharmacotherapy and things like that. But yeah, that's kind of super fascinating. And then doing that alongside private practice work, and also running my own business, which is like, why not just throw it all all in at one time. I run my own business with a colleague of mine, Kendall Alsop, who we studied together, doing our clinical masters years ago, and developed an ADHD group for adults experiencing ADHD, or living with ADHD, or have a diagnosis. And yeah, that's kind of cool. We run like groups in the community doing that. And yeah, it's like nice and busy, but
Lovely, lovely.
yeah.
What's the name of the ADHD program, and what's the name of your practice as well?
Yeah, so the ADHD program is called Doing ADHD Differently, and we run it out of our mind space. Psychology is our business name, and then I work clinically separate to that. So I work at another private practice called Beachside Physiotherapy and Psychology in Cronulla. So it's kind of a few bunch of those, but yeah, as mentioned, like happy to provide some websites and things like that for people to check it out.
Fantastic. Look, thank you so much. It certainly helps to also continue the conversation and potentially some listeners reaching out, and I think it's such an important consideration, whether being a clinician or in actual fact, just being human, thinking about
Mm,
how do I personally go out and access and engage with and communicate with health providers and try and, get the services that I need, because they are all constrained and, they're challenging and they're brand new.
yeah.
If we knew what our doctors knew or a specialist knew, then our literacy would be up there because, we
Mm,
wouldn't have to ask. The reason why we go to them is they understand how it all works. Hence such an important part of health, I think, is having really strong primary care,
yeah.
people having a really strong connection with a GP who can
Yeah.
also step them through it and say, this is what you should expect. This is how it's most likely to be. Um, and, some of the time a good GP can save you many months of hardship by simply sending you in the right
Absolutely.
direction.
Yeah.
So, I would always uh, encourage everyone to try and develop a strong relationship with what I would call a family doctor, someone
Mm,
that you is kind of like a family member. You have great
mm,
trust in. I know it's not always easy,
mm,
um, but it's such an important connection. You know,
mm.
we all want to
Absolutely.
select our friends for what they provide in our lives, and obviously we enjoy their time. We want to celebrate and laugh, and the rest of it. Well, I think we should definitely spend and be very conscious and thoughtful about who our health providers are, whether it's a GP or a psychologist.
Mm.
But I think our primary care person is a vital part of maybe even how you can increase your health
Absolutely.
literacy, because access to someone you can rely on, who you can trust. If they're high in it and you're leaning on them, you must be higher. You will have greater efficacy levels because you understand who you can at least go to for that advice.
Yeah, I couldn't agree more. GP, and even in the questionnaire, there's lots of questions about feeling supported and heard by GPs and things like that. So
Yeah.
yeah, I agree with you. Them as practitioners to kind of find someone who really like a family doctor who you can trust is so important. And I guess it's all about, breaking that cycle or helping people kind of improve their health literacy.
Taylor, such a pleasure to speak with you, and want to thank you so much about raising this as a topic and talking about it so eloquently and beautifully, because I think it's something that genuinely has huge outcomes,
Mm,
for health outcomes, irrespective of whether naturally our focus will be on mental health, on physical health. I think they're obviously very well connected,
yeah.
but it's a real important topic to not just gloss over, and certainly for me, um, something that's important is to try and take this away and be very deliberate. Try and increase my efficacy by thinking about, yeah, how can I increase my access? How can I increase how I understand
Mm.
the information? What, can I ask better questions from my health providers, or where would I go to get information? How could I clarify that? Who would I go to as, from a social network or even network of professionals I might know? Maybe remove some shame and talk about things that are, scary, so that I can maybe overcome those things to access health. So many aspects, and thank you so much for your time, and I wish you the best also with your private practice and your ADHD program, and also the research. So important to keep all of those flames alive, and obviously keeps you very busy.
Yeah, all very busy. Can guarantee that. No, thank you, Nesh. It's been so great, and I really appreciate your time too.
If you enjoyed this podcast, please support it by going to iTunes and putting a review, subscribe, share it via social media, and tell others about it. Start a conversation. It's listeners like you that make this able and possible, and why we bring in these guests to go out and share their knowledge and resources. And just lastly, if you are a psychologist and you want to go out and be part of a bigger team, develop your experience and get into some exciting work, come to strategicpsychology.com.au/careers and reach out. I'd love to hear from you.